This is Clinical Conversations. I'm Joe Elia. The American College of Cardiology, the American Heart Association, and other organizations have jointly released new guidelines on the prevention of atherosclerotic cardiovascular diseases. The guidelines are extensive, contain a few surprises, and will likely change your work as clinicians. I've asked Harlan Krumholz, a valuable guide in these matters, to share his reactions to the new guidelines. Dr. Krumholz is the editor-in-chief of NEJM Journal Watch Cardiology and a professor of medicine at Yale. Welcome, Harlan.
Thanks so much, Joe, and also editor of CardioExchange. Don't forget to let the listeners know about CardioExchange.
Okay, we will consider it officially pitched. There are four major areas in these guidelines. There's weight loss, lipids, risk assessment, and lifestyle. Overall, this is a big change?
You know, first of all, the American College of Cardiology and the American Heart Association are releasing to clinicians and patients an enormous amount of information here, and I think it's going to be hard for people to absorb it all, but let me just sort of focus your attention on the lipid guidelines, because I think that's where we have the most change and where patients and doctors are going to be most affected, at least in the short run.
Okay.
Over time, these issues around lifestyle and obesity can be discussed, but the lipid thing is sure to get people's attention right away.
One of the things I noticed, I was listening into the press conference from a couple of days ago about this, and one of the things that struck me immediately is that there are no more target levels.
Right. I mean, these lipid guidelines have profound changes and marked implications for clinical practice. I mean, first and foremost, they move away from the targets. You know, we've had this for so long, the idea of treating to target, know your numbers. We have patients who come in and wanting to know if they're at the right number, and we have doctors who have been paid based on the percentage of their patients that they've gotten to certain target levels and have been managed with regard to the quality measurement on this basis. I mean, this is a huge sea change, and it's one I think that will take people a little time to get used to. I've had many people come up to me and say, people who have been privy to these guidelines before release, and say, what am I supposed to follow now? And I think it's important for people to understand why this happened, and that this really represents an evolution of our thinking. And by the way, the movement away from targets has already been embedded in several guidelines and have already been published by the ACC and AHA, but they were STEMI guidelines, and they were stable angina guidelines, and I think this change in the cholesterol approach was not widely appreciated. And this really derives from the studies that have been showing us that the manipulation of someone's lab test, the modification of their lipid levels with drugs, do not always equate to changes in risk. Mm-hmm. And for the longest time, where everyone was focusing on targets, the idea was you could be agnostic to the drug strategy you used, and the whole point was just getting people's labs in order, and if you did that, you lowered their risk. And I think this is a recognition that if you are treating someone, you really want to lower their risk. It's not about just their lab tests. You do it for their lab tests in order to lower their risk, and the connection's not always there. So these guidelines are moving away from the idea that we're chasing targets, that we need to repetitively keep measuring people's blood levels and ensuring that they're within a certain range. This is sure to catch people's attention.
One of the things that got mentioned at that news conference was the fact that there will be a lot more people on statins. Is that your impression?
Well, yeah, I think there's some controversy about exactly what's going to happen. I mean, people may say, well, gee, if we're not, chasing targets, we don't have these targets, what are we doing now? And what the guidelines clearly do is pivot from a clear focus on lab results to overall risk and say to doctors and patients, what's really important is that you understand what your risk is, because whatever we do in decisions about using drugs, we ought to be thinking about what there is for you to gain, because the decision should be about what's the size of the potential benefit and what's the size of the potential risk. And the people who have the most to gain are the people at highest risk. And so the guidelines are pushing us as a general principle to consider absolute risk in making these decisions, to try to have in our minds what is it that someone's gaining from drug treatment. And now, by the way, all of this means the first steps for any doctor and any patient should be to implement lifestyle changes. I mean, you can reverse diabetes with weight loss. You can lower blood pressure. You can put yourself in a better position, virtually risk-free, if you improve your diet and activity levels. So this is really what we're talking about in lipid guidelines are about decisions about drug therapy. And the idea here is that people in whom drug therapy is initiated ought to be the people who have the most to gain. Now, what happened was that the guideline committee, sits in a room and they try to set thresholds. And in this case, what they did was they said, gee, we should be pulling together cardiovascular disease and stroke, and then we need to set a level that we're going to recommend treatment for. And they set a level of 7.5% or greater over 10 years. And what I'm hearing from them is when they worked this out, it turned out that more people would be treated. Now, from my perspective, there's a bunch of people sitting in a room and creating an arbitrary standard, and that's fine. I mean, guidelines have to be recommendations. They should be a point of departure with regard to discussions with patients, because what's high risk for me may be different than what's high risk for you. And how it will be operationalized is not exactly clear. We did a study a couple years ago we published in Annals where we took what we thought were reasonable thresholds for treatment, like taking forward those that had existed in ATP3, and said you could actually treat the same number of people and concentrate the treatment in the higher risk patients and save more lives and use fewer high-intensity statins. So I think, it's possible with this strategy to actually gain more from what we're doing, and the question sort of is what's the right threshold. What I'm hearing from the AHA is if you actually strictly follow these for the entire population, that in fact more people would be treated with statins. The presumption here is that you would also have a bigger benefit with regard to saving lives than we currently have now. But we have to sort of see how those numbers play out.
Yeah, you mentioned 7.5%. Were you talking about the 7.5% risk over 10 years from the pooled cohort equations?
Right. So this is another thing that people are going to need to know, which is that, so what they did was they actually had a separate committee that was thinking about how should we calculate risk. All of the listeners are familiar with the notion of these risk calculators, and that Framingham has one, there's a Reynolds one, there's a lot of them. And they generally use the same kind of factors. Some of them, have a little bit of a difference in what they have. These guys and gals, the team that pulled this together, created another one for people to use. It's going to be posted on the AHA website. I'm sure that you'll provide a link to it.
Yeah, we will.
And it's just another way to put in a lot of these risk factors that you're all familiar with, the smoking and blood pressure and so forth, and then try to come up with this estimate. So, yeah, they have not only set a threshold, but they have provided a calculator where you can put in the patient's characteristics. It's pretty easy to do, and see what the risk is. Patients can use it too. And again, from my perspective, this guideline shouldn't dictate who should be treated, but they're saying, gee, when we sat in a room, we thought 7.5% is about right. I think for any given individual, you've got to match the decision with your own preferences and goals. But the tool to calculate risk will be available.
Tell me, what do you think, first-year resident coming into you today saying, all right, so these things came out. What should I do tomorrow, or what should I be doing this afternoon that I'm not doing right now? What's a good first step for me to take?
Well, I think that this means that there are going to be a lot of conversations between doctors and their patients, and first and foremost, both for doctors and patients. I mean, there's no emergency. It's not like a new study came out with an entirely new finding that changes everything. This is about the codification of a practice that has been evolving and a clarification of our approach, which emphasizes a movement away from the targets, which emphasizes an assessment of global risk, what's the risk of the patient. And the third thing is it emphasizes proven drugs. It says just because a drug lowers LDL or raises HDL doesn't mean that it changes risk. And we have lots of studies now that are emphasizing that. So they say the drug that we know that lowers risk is statins. And so we really want to de-emphasize the other drugs that may modify lab tests, but we don't know about their impact on risk, or we have trials that show they don't change risk, drugs like ezetimibe and fenofibrate and niacin. And let's really, focus on the use of statins, proven medicine. And I think, to that resident, I'm saying, this is the beginning of conversations with patients where you're sitting down, you're saying, look, we're feeling now that it's not as important that we really singularly focus on a number and, to an obsessive extent, but let's figure out what your overall risk is And statins are risk reduction medications, really. That's, I think, how people should start thinking about them. They seem to reduce risk no matter what your cholesterol level is. And so the question is someone's risk high enough that it's worth it to treat them with a medication? And lifestyle hasn't helped, so they're going to go to medications. And if it is, then you should start statins. And I think it should simplify this. I know that the VA has already adopted many of these approaches, and there was some initial resistance, but many of the doctors are finding this easier because you don't have to have people keep coming in. You're not titrating the drugs to the certain level.
I see.
You're just figuring out what their risk is, and then you're putting them on medication like you might put someone on aspirin to lower their risk. And this is, I think it's going to take people a little time, but they should see that this could be easier. Fewer tests, an assessment of global risk, and discussions with patients about whether it's worth it to treat them based on the estimated size of benefit for them.
I want to thank you very much, Dr. Krumholz, for spending some time with us today and giving us a big overview of these new guidelines.
It's a pleasure. Thank you very much.
That was conversation number 169. All earlier conversations can be found at podcasts.jwatch.org. I'm Joe Elia. Thanks so much for listening.